So today we are going to discuss about the radiology of the pediatric brain, and we are going to cover first and foremost with regards to radiation protection, because most of the cases that we are handling for the brain is using a CT scan. So what I want you guys to understand is that we should not radiate child's skull unnecessarily. So unless you have a very proper indication, then you should proceed with a examination that has an radiation exposure, because we know that unlike the adults, in the child's marrow within the skull itself, there is already a 40 to 50% red marrow. So it means there's still a blood byproducts inside the marrow, and that's why it's still developing, and we do not want to radiate that area unnecessarily. Okay, so what are the indications for imaging in child's brain? So normally child will present with trauma, with loss of consciousness. Patient will come in with fits or seizures. On the other hand, they will come sometimes with developmental delay, that we're not sure whether is there any abnormality that associated in the brain. Child will come with a large head, because we'll examine the head circumference, and we noted that the head circumference is above the 95th centile. Then that's one indication, because we are afraid that there will be a hydrocephalus, for example, and also in a much older age group, when they can complain that they have a headache. So that is one of the clinical presentation. So these are the imaging modalities that can be done to image a child's brain: skull radiograph, ultrasound, CT, MR, and of course a cerebral angiography, which will be reserved for certain cases. We'll discuss that. And nowadays our skull radiograph has been least being done, because we have a more advanced CT scan, and also now the clinical assessment is more thorough. But normally skull radiograph is being reserved for cases of trauma, whenever you suspect a fracture, unless if you are not doing a CT scan. But if you are planning to do a CT scan, for example, the child's GCS is very poor, then definitely you can omit the skull radiograph anyway. Okay, so the indication of ultrasound is normally when the suspected brain pathology, but provided that the anterior fontanelle remains open. So that means it should be done at newborn age group until the age of 18th month, or even 12 months, because by then the anterior fontanelle would have starting to close, and you will lose some of the windows that you want to have for you to do the ultrasound, because ultrasound could not penetrate bone. Okay, so and whenever the anterior fontanelle has closed, then you might need to subject the child for a CT scan in cases of intracranial bleed, in trauma cases, infection, tumor, or sometimes in congenital abnormality. But you do have MRI to complement that, especially in cases that is not urgent, that you can schedule the appointment. And for a diagnostic digital subtracted angiography, DSA, so this is reserved in cases where we suspect any vascular malformation, for example, and arteriovenous malformation. So what about MRI? So MRI is a very superb or robust imaging, because it gives a very good soft tissue contrast, but it's not readily available, not unlike ultrasound or X-ray, and it requires a lot more effort in terms of you need to sedate the child so that the child will not move, because each MRI will require about 30 minutes to 1 hour examination. So if you need to have a good sedation so that child will not move and we get a good image. Okay, it's indicated in cases of tumor, ischemia, in cases of hypoxic ischemic encephalopathy, stroke, epilepsy, congenital abnormality, or even infection. So in the normal ultrasound, I think I've introduced this in much earlier um, lecture, whereby in any ultrasound, things that is black or anechoic, we call that, normally it represents the water, or even as a very soft tissue. And whenever you have a tissue interface are bright, we call that as echogenic. And in the brain, most of the time, it represents the correct plexus. Like in this case, this is a correct plexus that present in the occipital horn of the lateral ventricles. Okay, anything else are more black, but that doesn't mean that it's water, but it's also indicates some soft tissue, which is the brain parenchyma. And the more black, the anechoic one, like this one, that is the CSF fluid, the cerebrospinal fluid in the lateral ventricle. Okay, and this is how a coronal images looks like on ultrasound of the brain, and this is how a sagittal images looks like on ultrasound brain. So on sagittal, you'll be able to see the corpus callosum, very nice, a C-shaped kind of semi-luminous shape. And you see this is the cerebellum, which is slightly brighter, but that's not black. This is the normal appearance of a cerebellum, which is more bright compared to the cerebrum. So normally ultrasound we do in cases of germinal matrix bleed in a premature baby. We know that germinal matrix bleed will only present up to age of 32 weeks gestation. So if the child happen to born at that point or before that, then they are prone to get a germinal matrix bleed because it's still present. And after that, the germinal matrix will be reabsorbed, so that's why it's absent, and the risk of death is less. Okay, so in premature baby, when you see echogenic focus within the subependymal region, this is at the region of the frontal horn, then you have to suspect that it's a germinal matrix bleed. So this is what we see on a coronal, and this is what we see on a sagittal view. Okay, still it is bright, represent blood, but at the same time you can see the dilatation, associated dilatation of the lateral ventricle that can be associated with germinal matrix bleed. Okay, again you can see that echogenicity within the lateral ventricle that represent bleed. Okay, so if your neonatologist asks you what would you expect in cases of germinal matrix bleed on ultrasound, you should say it's an echogenic focus in the lateral ventricle. So sometimes ultrasound brain can diagnose intrauterine infection, especially when we see cases related to a dilated hydrocephalus. This is a dilated ventricular system, and also we see some foci of calcification this is at the wall of the ventricle, okay, or even at the basal ganglia. So again, echogenicity not just represent blood, it can also represent calcification. Okay, but of course you need to know the anatomy, because if the anatomy is not in the region where you expect a correct plexus should be, then most likely it is a calcification. But if it's big, then it could actually be a blood in the parenchyma. Okay, so it's vice versa. That's your differential diagnosis if you see a bright structure or materials in the brain. Okay, ultrasound can also diagnose a subdural empyema. It's basically a collection or pus in the region of the subdural. So this is the brain cortex. Okay, so that's the ventricle dilated, and then you see this is area of the subarachnoid, and then you have this subdural. So subarachnoid is near the cortex, the parenchymal cortex, but whenever you have a more external space which is near the region of the skull, then that is the area of the subdural. in a case of subdural impairment. Okay, it should not be anechoic, because if it's anechoic, very black, that indicates fluid only. But if you have a a combination of fluid plus some debris, so that indicates pus. Okay. um of Not often the Doppler can also being used, ultrasound Doppler, to monitor hydrocephalus. We can measure the resistive indices to of the artery to indicate whether is there any potential ischemia or not, but we don't normally do that as routine. Ultrasound can also diagnose a congenital abnormality. For example, in this case, these two are the normal ultrasound brain on sagittal and coronal, and you should be able to see, as I showed earlier, the presence of the corpus callosum here. But in this case, you do not see that, but instead you see all the gyrus has been clumped together, because you do not have the support of the corpus callosum up there. So this is in the case of corpus callosal agenesis. Now we move on to CT. For a normal CT, we have a plane, and if you want to introduce a contrast, then we get a contrasted study. So a basic normal CT appearance, if it's black or it is hypodense, then it can indicate fluid. For example, in this case, this is the fluid in the third ventricle. There is fluid at the CSF fluid in the suprasellar region. Okay, but whenever you see things that dense, very white, then you have, and very bright, then it can represent a bone. Okay, but normally anything in between will be shades of gray. Okay. So the gray matter, if you see here, that's the gray matter, which is the cortex, would be slightly more brighter than the white matter. Okay, but they are shades of gray compared to the so dark, so black, or so white. Okay, of the fluid and the bone respectively. Okay. Now, what is important in CT assessment of a child is, especially in infants or slightly older children, whenever we see the intracranial blade, because we do not want to miss a non-accidental injury. What happens is that the caretaker, whoever that is doing the problem, will shake the baby. So that's what we call the shaken baby syndrome. And since the head of the baby is relatively bigger compared to the neck and also the trunk itself, it's very prone to get blood, because there will be shearing of the vessel because of the movement. So we have to identify what kind of bleeding in the brain. It can be subdural hemorrhage, it can be subarachnoid hemorrhage, it can be intraparenchymal hemorrhage, intraventricular hemorrhage, okay, or extradural. Okay, right. So how do you detect all this now? So if you want to see an extra-axial means outside the brain parenchyma. Okay, it can be extradural, it can be subdural, it can be subarachnoid. So for you to differentiate that is for you to understand the anatomy. Unfortunately, that's what radiology is all about. But really, you need to know your anatomy very well. Okay, so we know that there are 3 layers of meninges in the brain. So if you see from coming from the skull, so that's the skull bone, you have the scalp outside there, and then you have a layer of a dura. So this is a dura layer, and then you have an arachnoid layer. Okay, and then you have the the red line is represent the pia, because the pia is very near and close to the cortex. It's actually enveloping the cortex, so it follows the cortex, and also it goes deep into the sulcus. Okay, whereas the CSF is located at the subarachnoid, so it located below the arachnoid layer. So the green space is actually the subarachnoid layer space, and this subarachnoid space can go into the sulcus, okay. But if it's dura, if it's in between the dura and the arachnoid layer, that is when we call subdural, okay. And that's why subdural is normally in subdural hematoma, the more common would be it happen, subdural hematoma happen in old age group, okay. But the epidural is more outside, it's more external, okay. So it's outside the layer of the dura, so that's why we call it extradural. And what extradural do is that it will push the dura away from the skull, and it gives this convex shape. But in the subdural, it gives a semilunar shape. And when we have a subarachnoid, again I told you that it goes into the sulcus of the brain, okay, the deep sulcus of the brain, okay. So if I give you these three images, number 1, number 2, and number 3, okay, you have 3 different types of extradural hemorrhage, okay. When you see here, it looks like, you know, it goes and crosses the sutures, it's semilunar in shape, very bright, and it's compressing on the brain parenchyma, but the fact that it crosses the suture, this is the coronal, where the coronal suture should be, and then it is semilunar in shape, then this is a subdural hemorrhage. Whenever you have a bleed that is parconvex like this one, and it does not cross the suture, okay, so we have this is the lambdoid suture around here, and that's the coronal suture, does not cross the suture, then this is actually a extradural bleed, commonly seen in trauma, but in subdural it commonly seen in non-accidental injury, okay, whereby when you see blood that occupies the subarachnoid space, because we know all these are the subarachnoid in the region of the sickle of Willis, and this is at the region of the Sylvian fissure, then this is actually a trauma, aneurysm, or it can also happen in cases of trauma, okay, subdural, extradural, and subarachnoid, okay. Now, infection. So infection, normally it happens in the region of the dura. I showed you earlier on the ultrasound, it commonly happen in the subdural, so it goes happen below the dura. Why is that? Because there's a lot of vessel around that region. So schematic diagram, this is the dura, so that's the arachnoid. Anything in between the dura and the arachnoid is the subdural space, okay, and then you have the subarachnoid space below the arachnoid, okay. Now again, you have to remember there's a lot of vessel around that region, okay. So what can it appear on the imaging? So if you have a infection in the region of subarachnoid, you have a meningitis, and also if it involves the parenchyma, meningoencephalitis. But what can it present as? Well, you can actually see a leptomeningeal enhancement. So like in this case, all the vessel in the leptomeninges in the subarachnoid space will be enhancing, okay, compared to the normal CT, with some of the linear enhancement here is actually the vessel. But if it's more florid, then it can indicate some inflammation of the meninges. But if it is absent, if there's absent leptomeningeal enhancement, then it will not exclude meningitis, because meningitis is a clinical and biochemical diagnosis. CT will not confirm the diagnosis of meningitis, okay. So it's just helping and looking at the complication. For example, if there's an abscess, okay, like this one, or a subdural empyema. So meningitis can have a complication of subdural empyema, so you will see a collection at the subdural space, okay. So this is the enhancing arachnoid, okay, and you can actually see, you know, a very complex looking fluid that represent the empyema. Or CT is used to see complication of meningitis, for example abscesses, Okay, whenever it involves the parenchyma, then you will get to see this rim enhancing lesion within the parenchyma cerebral abscess. Also a complication of meningitis. So that is the indication of CT scan in meningitis is not to diagnose meningitis, but to see the complication of meningitis. Okay, for example, subdural empyema or cerebral abscess. Okay, I mentioned about the MRI, no radiation, absence of tissue contrast detail. It can have some artifacts, okay, but because of the MR itself. But the thing about MR is that it requires sedation or even general anesthesia in younger patient. So as any other cross-sectional, okay, we have three major planes. The sagittal as if you're looking at the side, the coronal as if you're looking front to the patient, or axial as if you're looking from above or below the patient. Okay. Now, again, I said that why you need to have a sedation in children. Well, it's because if you have a motion artifact like this, you will never be able to diagnose anything out of this. That's why we need a good sedation or general anesthesia even to get a good image, so that when the child is immobile, then we'll be able to see the grey matter, the white matter, and all the details. So in a normal MRI, the two basic sequence that you need to know is the T1 and also T2. It's basically based on the physics of the MRI. So I will not go further into detail of this, but just understand in the brain, if you see that the CSF, the cerebrospinal fluid in the lateral ventricle is black, the grey matter is grey, the white matter is white, then this is T1. Okay, but if it's flip, the appearance is flip, is reverse, the grey matter is brighter, but the white matter is black. Okay, and the CSF is bright, so this is T2. T1 is basically helps in terms of delineating the anatomy, but T2 is majorly helps in terms of looking at the pathology. Okay, so this is how it looks like on coronal, on T1 and T2, and you have some other sequences related to flare, but that one is more advanced, so I will not go into details. So when you have a cross-sectional means either you do a CT or MR, because you will be able to do all this reconstruction and you get different planes of imaging, then you will be able to diagnose things based on all these planes. So for example, in tumor cases, definitely you need to have a cross-section study, because you need to know the location and how does the tumor behave and act to the surrounding parenchyma, surrounding tissue. For example, in this case, it's a suprasellar. Why I say that? Because I identified that this is the sella where the pituitary located. So this is the brainstem. So this is the suprasellar. And then when you know the location of the tumor, then you have a certain differential diagnosis. For example, in this case, it's a case of craniopharyngioma, because it's a common tumor, suprasellar tumor, okay, in children. And on MR, you'll be able to characterize the tumor further. Okay, so that means, again, I said T1 is not as bright, anything would not be that bright. Compared to T2, you will be able to see which one is more fluid. Like this one, this is more fluid, cystic component, and you have a more solid component. And the solid component will enhance. So this is the gadolinium, will enhance on the post-contrast study. And you know that this is the more solid, this is the more malignant component, this is just the fluid, the cystic component. Okay, so I would advise you to go back and then discuss about what is gadolinium, and maybe you can send me some of the your assignment, and then we see whether you are correct or not. So, and what is the indication and contraindication of gadolinium, because gadolinium is basically like drugs. you want to give to patient, but you have to know what's the contraindication, because it comes not without risk. Okay, so the third question would be, what is the side effect of gadolinium? So I believe that if you do this exercise, you will remember to be careful with gadolinium. All right, now okay, so imaging can also show the tumor extent. Like in this case, it compresses on the third ventricle floor, and it causes a bit of hydrocephalus at that region, and it goes to the more lateral aspect, okay, based on the different spleen that you have. And whenever you have a suprasellar or supratentorial or even a brain parenchyma mass, then most of the time we will do MRI spine together, because we want to see a drop metastasis. Like in this case, you see an enhancing nodules in the region of the corda equina because of metastasis from medulloblastoma. Okay, so of course MRI can help in terms of post-surgical assessment, so that's one of the good indication of post-surgical assessment tumor. And like in the case just now, post-surgery, you see how many percent of the tumor is being removed based on the imaging. Okay, other indication of MR is that because MR will give you a very good delineation between the grey and white matter, so you'll be able to see what's wrong with the grey matter and what is wrong with the white matter. Like in this case, it's obviously wrong, because obviously abnormal, because you see that this is a figure, like a figure of shape. You lost the sulcation, okay, and you lost a normal appearance of a brain parenchyma. So in the case of a congenital abnormality, okay, we call that as a lissencephaly, which is a smooth brain. It's basically abnormal migration of the neurons, all right, that produce this congenital abnormality. And sometimes the abnormality is more focal, then you'll be able to see lesion, one very focal, like here in the case of focal cortical dysplasia. It's a lesion that is cortical based, and it gives some abnormal signals on T2, and this is T1, a thickened cortex here. So in the case of FCD, focal cortical dysplasia, and patient often come with epilepsy. So whenever patient comes with epilepsy, we will do MR to exclude is there any focal cortical dysplasia that contribute to the epilepsy. Okay, if there is, then that would be removed so that we can control or even treat the epilepsy itself. Okay, CT or MR will be able to assess the ventricular system. So like in this case, you see that the ventricles are severely dilated. So this is the lateral ventricle, that's the third ventricle, that's the temporal horn of the lateral ventricle, also dilated. And we do the CT scan here, then we did the MR. Again, you see a better delineation of all the structures. And in this case, you see there is a narrowing at the cerebral aqueduct. So this is the third ventricle, which is so dilated, and this is the septum pellucidum, that's the corpus callosum. So third ventricle, before it goes into the fourth ventricle, you need to pass through the cerebral aqueduct. But if the cerebral aqueduct is stenosed, then it will cause triventriculomegaly. Okay, so in the case of cerebral aqueductal stenosis. Again, I showed that MRI is very, very well characterizing cases related to meningoencephalitis. Again, like the leptomeningeal enhancement that I showed you earlier. So if ever you want to leave this lecture, think about all the indication of ultrasound or CT scan or MRI whenever it's available, because it's very, very helpful for you to decide on your management and what to do next after you encounter the patient and after you examine the patient. Okay, so again, conclusion, do not unnecessarily irradiate the child's skull. Okay, whenever possible, use ultrasound or MRI, because that's very, very helpful in terms of no radiation, and the soft tissue contrast is very superb. Okay, and I think I will leave you with 5 cases. Okay, because at least it will stimulate your brain on what to see. Okay, so this is a case 1. It's basically showing the same thing, but 2 different patients. Okay, so in this child, you see case 1, there is a hyperdensity here at the region of the posterior interhemispheric fissure, and as you go there, you can actually see it goes slightly more anteriorly. So this is a subdural hemorrhage. Okay, again you will see that, again hemorrhage, subdural, in cases of non-accidental injury. So whenever you see an subdural hemorrhage, child presented with epilepsy, no history of trauma, then you have to think about or exclude at least a non-accidental injury. Okay, so at least we will be cautioned, and we further investigate. So this is an ultrasound. Okay, so ultrasound, again I talked to you earlier on ultrasound. If it's black, very black, then it's fluid. If very bright, it could be blood or it could be calcification. But if it's in between, like shades of grey, it represent the brain parenchyma. So like in this case, it's a brain parenchyma. But in this particular case, this case 2, you will see this is focus of hyperechoic, and the choroid plexus looks quite big. Okay, and there's also a big hyperechoic that appears to extend to the parenchyma, like some at this area. So this is a case of intraventricular bleed. Of course, we know when we do ultrasound, it should be either premature baby or neonates, because the endofontal is still present. So this child actually had intraventricular bleed plus bleed at the parenchyma. So this is a case of intraventricular hemorrhage. And when you see the ventricle is dilated, so with hydrocephalus. Of course, if there's a lot of blood inside the ventricle, inside a bag, then it will be blow up. Okay, so that's why there is intraventricular hemorrhage with hydrocephalus plus a parenchymal hemorrhage. So this is a stage 4, a grade 4 germinal matrix bleed. Okay. Alright, so this case, we have a CT scan. And then for the same patient, of course, when patient comes in, we will do CT scans much faster, especially in acute cases, right? So what we see is hydrocephalus, very dilated ventricles, third ventricle dilated, and you see a hypodensity at the periventricular, which indicates a CSF that has been passing through passage through the ependymal lining into the periventricular region that indicates acute hydrocephalus. Now what the child has is that this one, it has a mass in the posterior fossa. It's actually in the fourth ventricle that give rise to the hydrocephalus. So we know that we're dealing with tumor. So MRI was done to further characterize the tumor, and what we can actually see, the tumor is not very enhancing, so this is just minimal enhancement, but we know for sure this is in the posterior fossa, that is the cerebellum, and this is the brainstem. So posterior fossa, fourth ventricular tumor causing acute hydrocephalus. This is the CSF, transependymal CSF seepage. Then we know that we can narrow down the differential to a medulloblastoma with acute hydrocephalus. Okay, common tumor that rise from the fourth ventricle. What about this one? Well, there's already an arrow there, so you know that the abnormality is somewhere there. Okay, and this abnormality is only at one side, which produce a semilunar kind of appearance that crosses the suture going towards from frontal to the parietal and occipital. So that means this pathology is in the region of the subdural. But it's not bright, so that means it's not blood, but it is black, so that means it's fluid. But the fluid is not a clear fluid, because you can see some debris within that. And on top of that, you see some enhancement of the meninges adjacent to the brain. That means it's actually an enhancement of the arachnoid layer. So what can this be? So if there is enhancement, you know there is an inflammation. So we know that there is inflammation, we have to think about infection. So infection in the subdural with some debris within the subdural space itself, it is a subdural empyema. And often look at the midline. Okay, now the septum pellucidum is supposed to be midline, is already shifted, it's being pushed. Then we know there's quite a significant mass effect that's contributed by this subdural empyema, resulting in a brain edema. Okay, and that's why the mass effect is and the midline shift. So neurosurgeon will comes in, and then it will drain this subdural empyema so that the midline shift will reduce, so that the vessel within that region will not be compromised. Okay, so hopefully there's no impact. Okay, last case. I have a case. Patient presented with epilepsy, sudden epilepsy, while playing football. And then when we did a CT scan, and we saw this. So this bright thing, as I said, it could actually represent a calcification, a bone, or a blood, right, on CT scan. So this is CT scan. So you see this, it is not in the extra-axial, it is in the parenchyma. So if you project that thing here on the contralateral, the abnormality is somewhere here. So it is a parenchymal bleed. So in a 14 or 15-year-old child, adolescent, that comes in with this hemorrhage, unlikely it due to a hypertensive bleed. Okay, because hypertensive bleed is more common in all age group. So what can this be? So if you have a differential bleed in the parenchyma in a younger age group, then think about a blood vascular malformation. Okay, so sure enough, we give that differential diagnosis. Of course, we can't see the vascular malformation because there's a lot of hematoma. So the surgeon evacuated that, and then we did a digital subsection of angiography. So this is when the DSA is helpful, because you'll be able to delineate the vascular malformation. Like in this case, it's an arteriovenous malformation. So the thing about DSA is that you need to puncture the artery, and then bring in the wire through the vessel up to the vessel that we want. Like in this case, it's the vertebral artery, and then we inject contrast. So from there, it will opacify the artery that we intended to. Okay, so like in this case, it's a bleeding arteriovenous malformation causing an intraparenchymal hemorrhage. Okay, so I think from all the slide that I showed, basically you need to know the indication and what's the normal appearance of a ultrasound or CT of MR, and especially in intracranial bleed, have a look at how does it look like and where exactly the location, because you will definitely able to narrow down your differential diagnosis based on the appearance. Okay, so with that, I thank you for listening.